we actually, for the first time, have a medication that will help you maintain the weight loss.
Welcome to the Neuro Experience. Joining me today is Dr. Rocio Salas-Whalen, a triple board-certified endocrinologist, an expert in obesity medicine, and the world's expert on GLP-1s.
We know now that weight gain, obesity, is not a willpower. So having more willpower is not going to make the person lose weight.
We're going to get into the reality of what these medicines can do and what they can't do for women in midlife. It's also got an extreme inflammatory response as well.
When the visceral fat starts to decrease, inflammation starts to decrease.
We'll go into the effects of these medications on cancer, infertility, and brain health. A cutting-edge new study showed that GLP-1s slashes breast cancer tumors by 20%.
What's one of the highest risk for breast cancer? It's not family history, it's obesity.
GLP-1 meds slash dementia risk by 33%. That really caught my attention.
It leads to improvement, not just in dementia and Alzheimer's.
If you go deep and deep and deep, you see at the root of it really is inflammation. Dr. Salas-Whalen believes that we're going to live longer years in a healthier society because of this medication.
I predict that in the next few generations, there will be less type 2 diabetes, if any, chronic diseases, less cancer.
So you're saying that this could possibly be the end of chronic disease?
Yes.
To me, it sounds like a miracle drug. What's the future of GLP-1s?
I think we're going to make superhumans.
I'm Louisa Nicola, and this is the Neuro Experience. I'm so excited to get into GLP-1s with you. Before we do, I want to know a background. You're so passionate about the book, right? You're so passionate about GLP-1s, obesity medicine. You're triple board certified, which is phenomenal. You're a triple threat. You've got this book, Weightless. Let's start with why you're so passionate about it and a bit about the background.
I grew up in Mexico, where type 2 diabetes is the third cause of death in Mexico. Pretty much everybody in Mexico has a family member that has type 2 diabetes or that has passed away from type 2 diabetes. So during medical school, I was already interested in type 2 diabetes, endocrinology, and more because of the lifestyle that you had to work with the patient through change in lifestyle, obesity, weight loss to get good glucose control, right? So for me, it was like the challenge to get a patient to lose weight and better glucose control. And during my training residency in 2005, I met here in my hospital where I was doing my training, which is in Jacobi Hospital in the Bronx. I met Dr. John Eng, who is the one that isolated the first GLP-1 from the Gila
And he tried to sell
monster.
it from the pharmaceutical company, and they said no.
And they say no. He had to mortgage his house to do the patent on the drug. But so he was invited to our internal medicine conferences that some outside doctor comes, and I was blown away by what he was showing us. At that time, it was named Bayera. That's the first GLP-1 that was FDA approved for type 2 diabetes, and this is 2005. So there, it piqued my interest. So my training, endocrinology. As soon as I graduated from my training, 2010, I started prescribing GLP-1 to all my patients.
2010?
2010, it was Victoza, liraglutide back then, which is a daily injection for type 2 diabetes. And it was our best diabetes medication that we had, apart from insulin, right? But you're not going to start everybody on insulin. So most of our diabetes drugs cause weight gain on the patient. So either it improved their glucose, but there will be some weight gain. We didn't have one that actually targeted both things until the GLP-1s came. So we were starting using Victoza, approved for type 2 diabetes, and patients were coming back, I remember so well, not just with better glucose control that we've never seen, but with weight loss.
Okay.
So off-label, we started using it for weight loss, independent of diabetes, because GLP-1s don't cause hypoglycemia. In 2012 came the FDA approval for the first GLP-1 for weight loss independent of diabetes.
So when you say off-label, you mean right now? Is it still?
No. That was back in 2000.
Then.
So from 2010 to 2012, we used it off-label for weight loss. 2012, FDA approval for weight loss.
It's been touted as a miracle drug for everything. And this is what today's podcast is about, because I don't want to just focus on fat loss or weight loss. I would love to talk about the myriad effects that GLP-1s have. But in order to understand that, let's do a crash course on what GLP-1 is, glucagon-like peptide 1. What is it?
It's a hormone.
Okay.
It's a hormone that is made in our small intestine, in the L cells. That is where it's secreted. And what makes it the secretion happen is glucose, or the passage of glucose through the small intestine. So when we eat, it releases glucose, it converts into glucose, whatever we're eating, passes through the small gut, and it's released. We have receptors for this hormone all throughout our body, right? The first discovery was receptors in the pancreas, and that's why the first indication was for type 2 diabetes, because it stimulates the pancreas to produce more insulin in the presence of elevated glucose.
Yes.
Right? And it also improves insulin sensitivity, hyperinsulinemia. We have receptors in our brain, in our appetite center, right? We have receptors in our gut, in our stomach, where the satiety hormones happen, where the hunger hormones happen. So that's what GLP-1s are. They're a hormone where we have receptors through our body. We have receptors in our lungs, in our liver, in our kidney, in our heart.
So GLP-1 is a naturally produced hormone.
It has
endogenous.
one fault.
What?
Not everything can be perfect. That it's broken down within 2 to 4 minutes of its release by an enzyme, the DPP4 enzyme. This enzyme breaks it down within 2 to 4 minutes. And because of that, it's a very short life, right? GLP-1 analogs, the synthetic version that we know today as Ozempic, Zepbound, they're long-acting versions of our own GLP-1.
And is it true, because I've put out a lot of information about this on Instagram, mainly around the link between GLP-1s and Alzheimer's disease, and so I get thousands of comments, some of them good, some of them questionable, and there's a lot of upset people whenever I put this on the spotlight. I feel like there's still a lot of upset people, and I don't know why. And there's people saying, but we can produce it naturally. But you've just said that when we produce it naturally, it only lasts 2 minutes. How do we actually produce it naturally? What's it stimulated by?
Glucose, food.
So we eat.
It's produced in our gut, it's released, it acts very quickly, but it's broken down very quickly. So all those supplements that you hear about that to boost your own GLP-1.
Yes.
We don't have a GLP-1 deficiency, right? We don't have a lack of GLP-1. It's just that the enzyme DPP4 breaks it down very quickly. We have a medication that inhibits that enzyme. They are oral anti-diabetic drugs. They work well for glucose control, but never did we see the significant weight loss.
It wouldn't be acting on the brain.
Exactly. It's still, we don't get that effect.
Exactly. That's really interesting. And I'm guessing that because of the half-life only being 2 minutes, then that doesn't have a lot of time to travel.
Exactly. It doesn't cross the blood-brain barrier as well as the synthetic long-acting.
Great.
And we can see that with bariatric surgery, right? So one of the reasons that bariatric patients lose significant weight quickly, yes, there's a mechanical restriction, but there's a faster production of GLP-1 because they practically shorten the length from the food passing through the gut, right? Either removing a part of the stomach or a part of the gut in a bypass. So it's believed that there's more secretion, more rapid secretion of the GLP-1, but it's not long enough to cross the blood-brain barrier. So in patients post-bariatric surgery, we never see the control, the central control of the appetite. We have the mechanical control, but because it doesn't cross the blood-brain, it doesn't travel as fast, we don't see that food noise reduction, right? So if you think about it, bariatric surgery, it's kind of torture. Patients still hungry, but they just cannot eat.
So walk me through. So we know that there's receptors all over the body. Now we know what GLP-1s are. What happens when they go into the brain specifically? Let's talk about that, because what I've heard a lot of is a lot of people are reporting food noise, and the food noise has been decreased. Now I'm guessing that is a neural effect.
A dopamine effect. So we have receptors for GLP-1 hormones in our amygdala, in the hedonistic eating and drinking area of our brain, where we eat for a reward or anticipation of a reward, and it blocks that reward response. So if a person reaches for food, for comfort, for anxiety, boredom, depression, this hormone blocks that response. So the behavior changes. So let's say a person used to go for candy at night for anticipating a reward. If they're on this medication, because the behavior is there at the beginning, they reach for it, they try it, but there's no reward response anymore. So the next day, they don't go for it anymore, right?
Yeah.
So it quiets that.
In terms of the body, it's also got an extreme inflammatory response as well.
Yeah. Let's talk about obesity, right?
Yeah.
Because
let's talk about it, because are we still in an obesity epidemic here in America?
Let's talk about obesity. What happens in obesity? And obesity is basically there's higher percentage of body fat, right? There's visceral fat. Visceral fat is a pro-inflammatory tissue. It's releasing cytokines, interleukin-6, all the pro-inflammatory cells. It puts our body in chronic inflammation. This medication reduces visceral fat by reducing your caloric intake. This is how it works. You reduce how much food you consume, but in a natural way, right? It's not you holding back. It's not you being hungry and just thinking of the food. It just becomes like more controllable. When the visceral fat starts to decrease, inflammation starts to decrease. Now, something that I see in patients, and it happens very quickly, the patients mention that they feel less swollen even before they start losing weight. Like the first almost immediate effect within the week or 2 weeks of using this medication, they feel less swollen. And not significant weight has happened for us to say, oh, is the decrease in the visceral fat that improved the inflammation. This medication, when you start using it, it's going to cut your consumption of food by 50% almost immediately. It's going to cut the consumption of usually pro-inflammatory food that delivers that reward. Sugar, processed food, fried food, right? So you're immediately decreasing that consumption. Many times alcohol, you decrease the consumption. So you're decreasing already pro-inflammatory liquids and pro-inflammatory food. So that's why the quick relief that we see in patients.
Okay, everyone wants to know, Louisa, what creatine are you using? What protein are you using? Well, let me tell you. I've been adding Peori's Creatine Plus and PW1 whey protein into my morning routine, and the difference is real. My shake is almond milk, dark chocolate, PW1, and Creatine Plus. It tastes incredible. Sometimes I'll chuck a banana in there too, but it honestly tastes like this fancy chocolate milk, but it fuels me with clean, science-backed supplements. I always say you need to get the most amount of protein in your day first thing in the morning. This is why I have a smoothie. This is why I'm always having whey protein. Here's why this really matters. Women especially naturally have 70 to 80% lower creatine stores than men. That affects your strength, your cognition, even your mood. Since supplementing, I've noticed better strength in training and sharper focus during long workouts. And with Peori, it's honestly so clean. Every batch is third-party tested for over 200 contaminants. You can try it for yourself. I also use their vanilla bean as well. I love that flavor. Peori.com/neuro. Use code neuro for 20% off, even on their subscriptions. PUORI.com/neuro. Team, if you're like me and you like bread, then I have to tell you about one of my favorite rituals. It's been baking wild grain straight from the freezer. I'll put out a sourdough loaf or their seasonal pastries, and in 25 minutes, the whole kitchen smells like a bakery. Now, I can't believe this, but I came across a recent study that found that even if you are going to have bread, you want to have it in the healthiest way possible, straight from the freezer. So this is why I have become obsessed with wild grain. The convenience is unmatched. Literally, when you order wild grain, it shows up at your door. It bakes fast, and the slow fermentation process makes it easier on digestion. This fall, I tried their apple cider donuts and pumpkin cinnamon biscuits, and honestly, They tasted like something you'd line up for at a cafe. No joke. Go to wildgrain.com/neuro to get $30 off your first box and get a free tray of croissants. That's wildgrain.com/neuro. I've heard people also saying that they're taking a certain probiotic or a prebiotic that actually has GLP-1 in it. Is that a thing?
If it was working, there will be shortage of that probiotic and not of semaglutide or tirzepatide.
So let's talk about that, because we have this huge Ozempic wave, and I know that's just the GLP-1, but then we've got tirzepatide, which is GLP-1 and GIP. And I'm guessing there's going to be a triple threat coming out next year. Oh my gosh. You actually described this life cycle of GLP-1s like the iPhone.
Yes, I like to.
At the seed of it, they all call people. They all do the same thing, but every year they're getting updated. They're getting better.
Better, safer, less side effects, more potent, more efficacious, right?
Okay, so let's talk about what's the difference between GLP-1 Ozempic and then the GLP-1 and GIP from tirzepatide.
So GLP-1, which is semaglutide, it's a single hormone. Tirzepatide, it's a combination of two gut hormones, GLP-1 and GIP. And the retatrutide is the triple agonist, and this is going to be GLP-1, GIP, and glucagon. So together, and they're in phase 3B, so they're almost there. Yeah. And the results are beyond anything that we see in patients losing up to 40% body weight compared to what we see in tirzepatide, which the max is 24-25% of weight loss.
But what is glucagon doing extra?
So glucagon itself, it produces or increases the production of glucose in the liver, right? It's really interesting that they added this hormone and they're seeing even more significant weight loss. So really the mechanism of action in regards to more weight loss is not really known.
In your book, so you've A Doctor's Guide to GLP-1 Medication, Sustainable Weight Loss and Health You Deserve. You also have a strong love for midlife women. And you also are prescribing perimenopause, menopause. So you're doing a lot of hormone replacement therapy,
yes,
which I think right now that is being spotlighted. Mm-hmm. The word estrogen and menopause right now, we're hearing a lot about it, which is a great thing. No longer are we're hoping that women are no longer scared to, get on this in fear of breast cancer. Let's talk about midlife, and let's talk about estrogen's role in fat and that mid area, in that midsection where a lot of women are reporting to start gaining weight and they've got stubborn fat. What's happening there?
So after the age of 40, women gain 1 to 2 pounds per year on average. And we attribute that to the changes in estrogen, right? So we need estrogen. Estrogen is an anti-inflammatory hormone, number one, but also estrogen helps to maintain our body composition with lean muscle mass and maintain our body fat in our hips and our breast that is more protective for our fertile years. And what happens in perimenopause and menopause is that fat gets transported more centrally. We start accumulating excess fat intra-abdominally. And that's the visceral fat, which is the pro-inflammatory fat, right? That's what we call the bad fat that can lead to metabolic disease, increases your risk for cancer. It's pro-inflammatory. So all of those changes, while the estrogen starts to fluctuate during perimenopause, can affect the body composition of women. So many times women come to my office and say, this is not the way that I used to gain weight.
Yeah.
Now it's everything in the center, right? So they know their bodies and they recognize that this is not their normal pattern of waking.
If a female is taking hormone replacement therapy, whether it's estrogen, progesterone, and they also want to take a GLP-1, can they? They're not contraindicated against each other?
No, I call it the triple threat, as you mentioned earlier. For women, I think they don't replace each other, right? They have different function in our body, but they are options. And I always say that both HRT, menopause hormone treatment, and GLP-1 should not be the last resource, right? They should be first-line treatment.
That's interesting. But if someone's prescribed a GLP-1, are they going to be on it for the rest of their lives?
It's always what's the story of the individual patient that brought them to use or need a GLP-1, right? Every patient has a different story. So For patients that always struggle with their weight since childhood, they've had child obesity or overweight, they've been on diet most of their life, they've been in training programs, they go to camps to lose weight, most likely those patients will require long-term treatment. Let's say a woman that never struggled with weight, pregnancy, hits midlife, they have 30, 40 pounds that they cannot lose. They'll go on a GLP-1. Maybe there's a possibility that they will be able to maintain on their own once they lose the weight, if they never struggled with weight. But maybe the same woman has a very strong family history of obesity, and while she was working out in her 20s and her 30s, not with the kids, not with age, starts gaining weight, has obesity, most likely that she will require also long-term. But I always like to flip the coin. Using a GLP-1 long-term is not a failure, is not bad. It's actually, we have to see it in a positive way. And this is the beauty of these medications. And this is the difference of using a medical treatment and going into a crazy diet that is going to make you lose 30 pounds in 4 months, right? Is that we actually, for the first time, have a medication that will help you maintain the weight loss.
Maintain is
right?
the key.
It maintain the weight loss, because many things can take you there, but it's not maintainable, it's not sustainable. But for the first time, we can offer you something that is also going to help you stay at your goal.
How do you feel when people come to you and say, and this is talking like a social media perspective, when they say, you shouldn't get GLP-1s, you can just, what about willpower?
Yeah, I think that's very, very easy to assume when you see somebody with obesity that they have not tried to lose weight, that they have not done the legwork, that they've not seen doctors, nutritionists, trainers. They probably can give this person a cathedra in weight loss and diet and nutrition, right? I haven't met a single patient, and I have thousands of patients through the years, that came to me and said, I do nothing about my weight. I have obesity, but I'm sitting in my couch all day. I don't think about it. I'm not trying. And this is one of the reasons that I wrote my book, because it was so eye-opening, hearing story after story of my patients doing everything that we were recommending them. They were eating less. They were counting carbs. They were counting grams of fat. They were working out, cardio, spinning, you name it. They were doing everything, but it was just not working. So we know now that weight gain, obesity, is not a willpower. So having more willpower is not going to make the person lose weight. It's a multifactorial disease. We have hereditary genetics, right? And that accounts to 50 to 70% of the reason somebody's going to have obesity or be overweight, right? We know the parents' weight preconception, both mother and father, is going to impact their offspring's weight in the future.
Hold on.
Yeah.
The weight you are when you are pregnant can directly affect your unborn child and how they're going to live their life.
It's already increasing the risk for obesity even before conception if you start with obesity. And this is for both partners. So always my counseling for my fertile age patients that are thinking pregnancy, I always explain to them, look, this is the best for the future of your baby, the best for less complications during pregnancy, and even to improve your chances of fertility, right? Is starting conception at a healthy weight. Now, we have obesity that can be transgenerational, right? So, and I always do a very thorough family history on my patients. So I go 2-3 generations above the patient, and you always see a pattern of obesity. So I put to my patients on the table, I said, you have the possibility, your grandparents, your great-grandparents didn't know, your grandparents didn't know, your parents didn't know that their weight affected your future weight, but you know. So you can break that transgenerational hereditary of obesity.
Oh my goodness, that is huge, because then they stop passing it on.
Exactly.
I mean, to me, it sounds like a miracle drug, right? But what type of scientist would I be if I didn't look at both sides of the coin? Now, when I put this out on social media, I get so many comments, and we're going to go through them, and maybe we can myth bust now. I've been told that taking a GLP-1 can increase your risk of getting certain types of thyroid cancer. Is this true?
That is not true.
Why is this a thing?
So in the studies in the laboratory, it was found that some mice, there was a higher occurrence of medullary thyroid carcinoma, which is a very specific and aggressive thyroid cancer, right? It was never reproduced in humans. It has not been reported in humans. Other types of cancer have not been reported in mice, less in humans, right? And somebody having history of thyroid cancer does not disqualify them to use a GLP-1. And I think that's a big misconception and a myth, except medullary thyroid carcinoma. That's pretty much our only absolute contraindication on a GLP-1 is if the patient or a first-degree relative has history of medullary thyroid carcinoma.
But why would that be? What's the pathway there?
So we don't know, but we don't want to increase the risk of the patient to develop it, right?
Keeping in mind that study was done on mice and not replicated in humans.
And again, we have 20 plus year data, clinical data of GLP-1 medications.
Over the summer, I became absolutely obsessed with body oil. And I'm really picky about my skincare, but Osea's Undaria algae body oil has earned a permanent spot in my routine. The first time I used it, my skin felt silky and sculpted, and I even had someone compliment me because I was glowing. What I love most is how lightweight it feels. It's not greasy, and the fact that it's clean, vegan, and sustainably sourced. Knowing I'm putting no harmful chemicals on my skin while still getting amazing results makes me trust this company even more. If you want glowing skin and if you want to be able to put oil on your skin that is not going to make you feel gross, you will see the difference. Just go to OseaMalibu.com, use code NEURO for 10% off. They also ship you free samples with every order and free shipping over $50. That is Osea, O-S-E-A, Malibu.com. Ladies, I used to dread bras and shapewear, either uncomfortable or unsupportive. Then I tried Honey Love and it completely changed things. Their bras lift and support without underwire, so I'm not adjusting all day. The new Cloud Embrace bra is my favorite because it actually feels like a cloud but still gives you real support. Their shapewear is unmatched. It actually enhances your curves without squeezing the life out of you, and it stays in place. It's become my go-to foundation for everything I wear, especially when I go out at night. You really want to treat yourself to really good underwear that shapes you well, that holds you tight, and that's not going to break through wear and tear over time. So if you want to treat yourself to the most advanced bras and shapewear on the market, go to honeylove.com/neuro to save 20% off your entire order. That's honeylove.com/neuro. Now we have, I don't know if it was done in humans, but maybe you can talk to me about that GLP-1s actually show a reduced risk of getting breast cancer, which I think is phenomenal. I'm going to read it here. A cutting-edge new study showed that tirzepatide, which is the GLP-1 and GIP, the dual drug, already hailed for impressive weight loss, slashes breast cancer tumors by 20%.
And, you know, it's not a surprise.
That's huge, 20%.
And I'm going to tell you why. What's one of the highest risk for breast cancer? It's not family history. It's obesity. Colon cancer, prostate cancer, thyroid cancer, stomach cancer. The highest risk is obesity. So if you are decreasing obesity, you're going to decrease the risk of cancer. Remember, you're going to have some anti-inflammatory benefits from this drug, right? So what drives cancer? Inflammation, right? So if your immune system is concentrated in inflammation, you cannot have the proper response for viruses, for cancer cells. But if the inflammation is reduced, then your immune system can work and protect you. Actually, when we talk about inflammation, this is probably where we see all of the GLP-1s and Alzheimer's related dementia, right? At the seat of all of this is the research that I have thrown myself into over the last 10 years. We do see, if you go deep and deep and deep, you see at the root of it really is inflammation as a cascade to all the other different risk factors. And what you're saying here is if we can downregulate inflammation, which is what we're all trying to do,
We're all trying to do that, right? We can minimize the risk of getting breast cancer by 20%.
Yes. So GLP-1s are neuroprotective.
They are neuroprotective.
They are neuroprotective. Also, it improves insulin sensitivity in the brain, which we know hyperinsulinemia and insulin resistant. It also drives cancer.
You mentioned earlier, and I just want to go back to it and know if this is the same effect. You said you're seeing in a lot of your fertile females that you see that are not really in midlife, that you're getting better conception rates because of GLP-1s. Is that also because obesity and insulin resistance is causing maybe
infertility?
Infertility.
Yeah. PCOS, polycystic ovarian syndrome, is the number one cause of infertility in women, right? So by improving that with a GLP-1, you improve the chances of conception, right? So that you hear Ozempic babies is because many women that thought that conception was not an option for them, that they've tried, now they go on a GLP-1, they start losing weight, no inflammation, they start having a regular cycle, and boom.
They're happier.
And they end up pregnant. Exactly.
They've probably got more muscle mass.
They want to have
to the gym.
more intercourse, you know, they feel confident, mental health, and that's what happens.
So, Dr. Salas-Whalen, I'm going to read something to you very dear to my heart that I posted on Instagram that went quite viral. GLP-1 meds slash dementia risk by 33%. And this was a study published in JAMA Neurology in 2025. They analyzed nearly 100,000 people aged 50 years and older with type 2 diabetes who were on GLP-1 medications and saw a 30% reduction in Alzheimer's disease. That really caught my attention. It really caught my attention and made me so happy.
Yeah, I mean, again, if you know the physiology of a GLP-1, how they work, it leads to improvement not just in dementia and Alzheimer's, chronic disease. I predict that in the next few generations, there will be less type 2 diabetes, if any, chronic diseases, less cancer, right? So this is going to be a snowball effect in health.
I don't think this is a misconception. I think this is a real thing, muscle loss, right? So you've probably seen patients, maybe not in your clinic because you're doing it correctly, but patients who are losing so much weight that they become skinny fat. Well, what is that?
Great. I'm very happy that we're talking about muscle because muscle has such a positive impact in inflammation at the same level as comparing it to a negative impact from visceral fat. By increasing muscle mass, muscle is an endocrine organ. It produces hormones called myokines, which these hormones are anti-inflammatory. The most potent anti-inflammatory organ in your body is muscle. So when we're talking about high-risk mortality from cancer, muscle also helps, right? And muscle will help you mobility, independence, strength, right? It's not just the decrease in the inflammation, but I always say you get more for your buck building muscle than concentrating so much in fat.
And it's so hard for women to build muscle as well, and men too, but like as you move through midlife, you know.
Yeah, and also we have, there's this idea in midlife women, especially 50s, that they think that they're going to pick up dumbbell and they're going to pop muscle and they don't want to look like that, right? But you have to, that has to be your full-time job, your profession to be a bodybuilder, to actually look like a bodybuilder. But if you're going twice a week, 3 times a week, you won't get bulky, right? Back to your question, yes. So you're going to have a decreased consumption of food, right? So one of the things that people cut first whenever you are eating less, it's protein. So you're not only just consuming less amount of calories, but you're cutting your protein consumption by half or even more when you're on a GLP-1, right? So any doctor prescriber that knows how these medications work, they always have to start the first evaluation having a talk about nutrition and talking about the importance of protein in their diet. If they're going to consume one thing while they're on a GLP-1, should be protein. They should be doing body compositions to see what is it that the patient is losing, right? These are sophisticated drugs. We need sophisticated ways of seeing what's happening with your weight.
And by assessments, you're talking do a DEXA scan, for example.
Do a DEXA scan, do impedance machines. Those are the most easy to have in the office, right? I mean, they're very close to a DEXA scan. Our gold standard is an MRI, but we're not going to do MRI on every single patient. So do some sort of body composition of whatever you are available. You need to measure muscle mass, percentage body fat, and visceral fat whenever somebody is starting on a GLP-1. And in fact, anybody, even if you're not a GLP-1, you need to know what's your body composition.
How often do you recommend looking at that if you're on it, just to track progress?
If you're on a GLP-1, what I do with my patients, I do it every 8 weeks. No earlier than that.
Wow.
Yeah.
Every 8 weeks.
8 to 12 weeks, I see my patients and I do a body compositions. Why? I want to see what's happening with muscle. The fat loss is going to happen.
Yeah.
I want to know how you are maintaining muscle in this journey.
So if you see, what's the standard average starting dose? Is it 2.5?
2.5 in tirzepatide, 0.25 in semaglutide.
Milligrams,
yeah.
Okay, great. So they take that for a certain amount of time. And then if you see that they're losing too much muscle?
If they're in the initial dose, it's a nutrition. It's the nutrition. They didn't get the message that they need to get around a minimum of 100 grams of protein a day. And many times the patient needs to see that in the body composition. So the first visit is always like the first follow-up, it's a eye-opening visit. If they were not doing the protein, then they see that they actually lost 2-3 pounds of muscle, and then they get it, right? So there is always I go over with my patient, I say, walk me through a day of protein in your diet. Walk me through a day of your food. When you woke up until you go to bed, I want to know what is it that you're eating and how you're counting grams of protein. And many times the patients are overestimating, or they're really getting 70 grams of protein, 60 grams of protein. And we're going to see that. It's difficult, right? The $65 million question, how do you build muscle but continue to lose weight? Because to build muscle or to preserve muscle, you need to eat.
I'm still asking that question.
So it's getting creative in the way that you're going to be able to get the protein. The best recommendation, and all of this is in my book, and that's one of the reasons that I did my book, is having 4 portions of 25 to 30 grams of protein each.
And that's achievable on a GLP-1?
That is completely achievable. I have patients there on 15 milligram, the max dose of tirzepatide, and while they get 4 portions of protein a day, they're building muscle.
When you said earlier on, you said we're getting better with the drug. Every new one that comes out, we're going to keep getting better and better with less side effects. What are the side effects?
So the most common side effects, and again, I'm going to talk about Ozempic or semaglutide, nausea, constipation. Patients feel they are on something, like you're like a little bit nauseated, disgusted, you don't want to think about food. Tirzepatide, we don't really see that. Patients don't feel they're taking a medication. It happens more naturally, so there's less nausea, no constipation I see usually with Zepbound, no vomiting. Diarrhea can happen with either of the versions that we have, with anything that is fatty or fried or heavy processed food that can give diarrhea. But they're controllable, right? They are, and you can anticipate certain meals and avoid certain meals to avoid the diarrhea. It's not that you're going to go on a GLP-1 and you're going to have diarrhea.
I think the best approach to taking this is not seeing it as something that's going to help you completely eliminate food. I think it's something like a companion, your personal trainer at home that's going to be there to tell you, hey, you don't really need the donut.
Yeah.
That's fine. Skip it. Have your meat, have your veg. In
my book, I mentioned it's your GPS, right?
I love that.
This is a journey, but GPS is your navigation, and GPS is G for GLP-1, P for protein, and S for strength training.
Oh.
That is the prescription that anybody going on a GLP-1 needs to get. You need your GPS. Otherwise, you're not going to have the right results.
Okay, team, here's something wild. We all have 2 ages. Our actual age and our biological age. And most people are 10 years older on the inside than they look on paper, which is quite scary. I've been taking Field of Greens, and the science is powerful. In a university study, participants slowed their biological aging just by adding Field of Greens. No changes to diet, exercise, or lifestyle. For me, it's peace of mind knowing I'm putting real fruits and vegetables, doctor selected for heart, lungs, metabolism, and cellular health into my body every day. By the way, I did my biological age test, and guess what? It came back 11 years younger than what I am. Honestly, I've been taking Field of Greens. I'm not saying that that's the only thing that's adding to my biological age, but hey, it feels like I'm giving my cells the fuel they need to age slower. You can check it out for yourself, and you can check out the study yourself at fieldofgreens.com. Use code NEURO for 20% off. That's fieldofgreens.com, code NEURO. As a neurophysiologist, I've had those moments where I second-guessed what I heard through a stethoscope. Was the subtle murmur real? Was I missing something in a noisy environment? That's uncertainty, and it's extremely stressful. I'm so excited about this new device, Echo's digital stethoscope. Honestly, it amplifies sounds up to 40x. It cancels background noise and even uses AI to detect murmurs or atrial fibrillation. It feels like having a cardiology consult right in my pocket, helping me be more confident in assessments and give patients the best care possible. If you want to hear with precision, if you are in the medical field and you don't want to use the Littmann boring stethoscope anymore, you need the EcoHealth stethoscope. Just go to ecohealth.com/neuro to get $50 off plus a free customizable chest piece cover. That's ecohealth.com/neuro. I don't know if you've seen, I'm so happy you put it out there about actually getting the GLP-1s is because the Kardashians, and I think Kourtney Kardashian, who has a supplement line, has got these special marketed supplements. I think they're gummies and they're GLP-1 gummies. Bullshit, right?
Completely.
Yeah. Okay, great. I'm glad you said that. How do you feel about microdosing for a healthy individual? Let's actually talk about this because it's a real thing. And by the way, I don't know if they're doing this. Is there any black label GLP-1s happening yet?
No.
Okay, great. What's microdosing? It seems to be the new in thing.
Let's talk about that.
Yeah.
Let's clear things up with microdosing. The term microdosing means that you're going to be using a smaller dose for some effects than the therapeutic doses, right? Whenever a drug is studied, they study different doses, and they start with the first therapeutic dose where they saw any effect of whatever the goal or the outcome was, right? So let's say for weight loss, 2.5 milligram intersepatide is the first therapeutic dose that you're going to see effect. Mm-hmm. If you go below that, well, you're not going to get the effects at a therapeutic level, right? Now, if somebody tells me, well, I don't need to lose weight, I'm healthy, I just want to get all the other benefits from GLP-1s, the anti-inflammatory effects. First of all, if you don't need to lose weight, I am assuming that your body composition shows me that you have more muscle mass, your percentage body fat is in range, and you have a very low visceral fat. If that is the case, I know by looking at your body composition that you are strength training, that you are eating healthy, right? Otherwise, you wouldn't have that body composition. So if you're doing already that, you don't get extra benefits from being on a GLP-1. You're already getting the benefits from muscle mass and protein in your diet and eating healthy, right? If you have a low percentage body fat, a normal visceral fat, and muscle mass, that already tells me your lifestyle. You're already getting all the benefits. Yeah. So many times when somebody says that and we do a body composition, surprise, surprise, you're skinny fat, you have sarcopenia, obesity, your percentage body fat is 35, is 40, and you are under muscle and your weight on average looks normal. Your BMI is 22.
You could look good on the outside, but on the inside, your organs are dying.
You need the full dose. Right? Yes. You need to lose the percentage body fat. You need to lose the visceral fat. And for that, we need the therapeutic dose. Yeah. So you're not really getting anything because if you don't need it for weight loss, then I'm assuming that you are in a good health. But if not, then you need the therapeutic dose to get the effects, right? Yeah. Microdosing can be useful in the maintenance part. Let's say somebody lost all their weight on 2.5 milligram on the first dose of a GLP-1 of tirzepatide. Then for maintenance, we cannot go lower than that, right? There is the option of underdosing. I don't like to call microdosing. I like to call it underdosing. But they already are there and it's just maintenance. That's where the microdosing benefit will come in.
So as long as you've got all your ducks in order, fat mass, muscle mass, non-sarcopenic.
You're not going to get anything extra from using a GLP-1. You're already achieving that by your body composition.
Interesting. Okay.
But if it's the opposite, then you need the full therapeutic dose.
Yeah. I can only imagine that you're probably seeing both men and women. By the way, this is for, you're probably seeing 50-50 men coming in saying, bringing them to tears that you've helped them.
So when somebody is coming to me for the first time, they're most of the times it's something, they want to improve something external. They want to look a certain ways. They want to fit in certain sizes. But as we go through this journey with the GPS, it flips. It becomes about strength. It becomes not about how they look. It's about how they feel. Because if you have somebody who loses 30, 40 pounds, but they lost 20% or 30% of muscle, they don't feel healthy. They don't feel strong. They feel weak. They feel tired. They start losing their hair. They start skin drying and sagging, right? We need protein for hair. We need protein for skin, for nails. So whenever a patient is losing muscle, they're losing hair. If a patient is not losing muscle and even building muscle, they're not losing hair.
Interesting, because of collagen.
So they go together. So if you're losing hair, you're losing muscle.
What's the future of GLP-1s?
I think we're going to make superhumans. I think for the first time we have...
If done correctly.
If done correctly, 100%.
If they've got your book.
If they have my book, yes. Whenever somebody is going to finish reading my book, there won't be enough experienced providers. But with my book, I want to have enough experienced and educated patients. Right?
I love that.
For the first time, we're having interconnection with the fitness world, doctors and trainers, right? I've never referred so many patients to working out, lifting weights, to trainers as I do now with my practice with GLP-1 medications, right? So the medication is going to take care of helping you lose the body fat. And as you feel lighter, as you feel stronger, as you feel healthier, right? Mental health. Once you remove the pressure of weight loss to exercise, it takes a different form, right? People exercise for health, for strength. It's amazing that my patients, in half of their journey, they start coming and what's my muscle? Did I lose muscle? Did I gain muscle?
Really?
It flips completely. Now they want to know what's happening with their muscle, if they're building it, if they lost it, how can they regain it? So it shifts the attention completely. Also, patients that don't lose muscle, they can maintain the weight loss with a smaller dose, or those are the ones that maybe will be able to stop the medication. For those that lose significant muscle and they don't regain the muscle, they need maintenance on very high doses of the medication. I cannot drop the drug because the drug is doing 100% of the work. But if you bring muscle into the table, it balances out and you don't require the medication at a higher dose or even long-term.
So you're saying that this could possibly, quite frankly, be the end of chronic disease?
Yes. We're not going to see it in our generation, but I believe in the next second or third generation, yes.
The end of obesity.
Of type 2 diabetes.
Yeah.
Osteoarthritis. I mean, there's endless cancer.
I wonder, that's insane. I wonder what the next thing is going to be after this. We've got one in phase 3.
Yeah.
B trial, like it's a triple.
What is coming out, which the ones
do you know even after that what's going to happen?
The ones that are on phase 3 or even phase 2B, we have a monthly injection.
As opposed to a weekly?
As opposed to a weekly, which what the studies are showing is a total weight loss about 15 to 16%. Again, with tirzepatide, we're seeing 24%, right? So less, so it will be a good option for maintenance, right? It may be something that somebody can take once a month for long-term maintenance instead of a weekly injection. right? So that's one. Then we have a drug, which is going to be interesting to see. Novo Nordisk has a drug that inhibits muscle degradation.
Myostatin?
Yes.
Oh.
And Eli Lilly has tirzepatide, right? Before, Novo Nordisk used to have semaglutide and this antibody for muscle, and they were going to do it. But now...
In one?
Now Eli Lilly bought the muscle-preserving formula. So it's going to be interesting if they combine it with tirzepatide in the future.
Oh my God, that's so interesting because peptides now are becoming more abundant as well. You know, I think the most notable one is BPC 157, which is more so to make your muscles not feel sore anymore. But if it can be combined with myostatin, that's going to be out of control. It's going to be insane.
And if you think about it, also women in midlife now with hormone replacement therapy, right now they're going to feel, now they're going to be sleeping well. So they're going to be in more energy to exercise and better mood, and then losing the body fat with the GLP-1. Now we can really concentrate on muscle and becoming strong and becoming fit.
The future is female. I think the men better watch out. Because if we have all these women walking around in midlife feeling
that we can
the way they did when they were
anybody.
25, I'm telling you, it's game over.
Let me tell you, better. Because at 25, you have no idea of anything of how your body works. I mean, it's changing. I have a lot of young
how
patients.
Life works,
So it's going to be different for them. A woman now in midlife can feel much better than what they did at 25.
Before we finish, why don't you tell me, when does the book come out? When's it released?
So my book is going to be published here in the US and Canada in December 30th of this year. Also an audiobook. And in UK, Australia, which you're from, New Zealand, India, and South Africa, January 1st. And Latin America and Spain is going to be mid-2026.
Oh my gosh, so next year is going to be huge for you. Can we get it on pre-sale yet?
Yes, you can pre-order it in Amazon, Barnes & Noble. You can pre-order my book.
So we're going to put that in the show notes below. Dr. Salas-Whalen, you not only have educated me a lot, you show me how this scary thing, you know, about getting older, right? It's such a scary path, but it's not when you are well educated and you can go to a trusted physician like yourself who really has good intentions for people. So thank you so much for coming on the podcast.
Thank you. Thank you so much for having me. Always a pleasure.